Hello and welcome. I'm Manhal Najdy. I'm a consultant gynecologist with special interest in cancer diagnostics, and I'm the unit lead for Cancer Diagnostics and Oncology at the Buckinghamshire NHS Trust. Today, I'll be guiding you through a rather important update on the postmenopausal bleeding, particularly in the context of women's use for hormone replacement treatment, or HRT. This is a part of a pilot educational initiative taken by the Thames Valley Cancer Alliance, and it's aimed at supporting our GPs in primary care with their everyday referral decisions. Postmenopausal bleeding, or PMB, is defined as vaginal bleeding that occurs more than 12 months after a woman had experienced her last menstrual period. A diagnosis of menopause in the UK is at the average age of 50 to 52, and it could be biochemical diagnosis. However, the clinical diagnosis can be appropriate. While the diagnosis of endometrial cancer could only involve 10% of these cases presenting with postmenopausal bleeding, the NICE guideline number 12 sets referral criteria for women aged over 55 with unexplained postmenopausal bleeding episodes to happen on the urgent suspected cancer pathway or within 2 weeks of reporting to primary care. For women under the age of 55, a cancer pathway referral can also be initiated for women who would present with postmenopausal bleeding with other risk factors that I'll refer to later. The use of HRT had increased 5-fold over the past decade, and with this rise, we are seeing more postmenopausal bleeding presentations. Local audits had shown over 50% of PMB referrals are involving women on HRT, yet less than 0.5% of these would result in a cancer diagnosis. This contrasts with a 10 to 15% cancer detection rate for women with PMB whom are not on HRT. So the key message here is to balance safety with avoiding unnecessary investigations and patient anxiety. This has significant implications where we are facing pressures on resources like ultrasound scan capacity. In secondary care, we are facing pressures on resources like specialist clinics and also outpatient hysteroscopy access. National efforts, including the Get It Right First Time program, GIRFT, had acknowledged these strains, and the work is underway to streamline the services. Many trusts across the country are developing a dedicated performers for referral of women with postmenopausal bleeding whilst on HRT. But until this is in action, we need to develop some strategy on how we can get better on our triaging process. We should start by identifying high-risk factors such as a BMI of over 40, unopposed prolonged use of estrogen for beyond 6 months, or hereditary cancer syndromes such as Lynch or BRCA syndromes. These patients would warrant a referral on the urgent suspected cancer pathway whether or not they are on postmenopausal bleeding. But for low-risk cases such as a BMI that's less than 30 or polycystic ovary or metabolic syndromes and insulin resistance included, we could consider a more measured or a tailored approach. The use of endometrial thickness can be a good guide. If a woman had been started on HRT and that was combined HRT, the threshold can remain at the 4 mm before referral is made. But for sequential HRT and based on evidence, we can use the 7 mm threshold to be considered for referral on the urgent suspected cancer pathway. It's important to always remember persistent symptoms, i.e. bleeding, even with normal scans, and regardless of the risk factors, it can still justify a referral to be considered for outpatient hysteroscopy under the suspected cancer pathway. Let me clarify this a bit further. When should we act on an unscheduled bleeding for a woman on HRT? If a patient has one major risk factor previously mentioned, or 3 of the minor risk factors, then you should refer on the urgent suspected cancer pathway, and this is regardless of the bleeding pattern. But for a woman with low risk factors, you could try up to 6 months of HRT adjustment, which is something you all had used to do. If the bleeding then continues, then an urgent pelvic ultrasound scan can be arranged, but the referral might not necessarily be under the 2 weeks wait or the urgent suspected cancer pathway unless there is a significant thickening on the lining of the womb from the ultrasound scan. And now let me elaborate more about the irregular bleeding that women experience in the first 3 to 6 months of starting the HRT. We should expect some irregular bleeding that's often due to hormonal adjustment, improper absorption, and other factors. It might be appropriate to alter the progesterone component by increasing it for women who had just started HRT, i.e. within 3 to 6 months, and that's particularly if the bleeding pattern is troubling them. For more in-depth guidance on this subject, I would encourage you to refer to the British Menopause Society recommendation available online. Finally, thank you very much for your time and attention, and I hope this session would help you clarify when and how to refer women with postmenopausal bleeding on HRT. Thank you.